Hello, everybody. This is Billy Rubin. Today we're going to be talking about diabetes diagnosis and management. Okay. Typical presentation is going to be polyuria. Okay. It's because whenever you get to 180 milligrams per deciliter, um, blood, blood glucose, serum glucose, you're going to exceed the transporters in the kidney. You're just going to be peeing out glucose. Okay. Typical presentation for someone with type 1 diabetes is going to be a kid. They're going to present with DKA, okay? And then typical presentation for somebody with type 2 diabetes is going to be a pretty asymptomatic person, but they're going to have elevated blood sugar, okay? You're just going to pick that up on labs. Further evaluate, they got type 2 diabetes. Uh-oh, right? Okay. Diagnostic criteria for diabetes. All right, let's start with good old diabetes. Okay, so initially, your plasma glucose test. Your plasma glucose. Keep in mind this is a fasting plasma glucose test. Okay, fasting plasma glucose is going to be greater than or equal to 126 milligrams per deciliter. Standard, right? Okay, that's one of the tests. There's more. All right. Another test is a 2-hour 75 gram glucose tolerance test. Okay, I'm just going to put GT here. The glucose tolerance test, if you measure that glucose tolerance after they took that 75 grams of glucose and you see that it's greater than or equal to 200 milligrams per deciliter in the blood, that's also a good sign they got diabetes. All right. Next test is your good old hemoglobin A1C. Okay. You measure this one and you get a level greater than or equal to 6.5%. All right. We're looking at somebody who's on track to being diagnosed with diabetes, right? I mean, come on. And then we're talking about somebody that comes in with symptoms, a symptomatic patient, right? You measure their random blood glucose, and that thing is way over. It's about 200, greater than or equal to 200 milligrams per deciliter, similar to our 75-gram glucose tolerance test. You got a good chance of them having diabetes, okay? Another thing to remember here is a big number 2. All right, why do we want 2? Because we got to have at least 2 of these tests being positive or the same test being positive twice at 2 different times. That's how we make the diagnosis of diabetes. You can't just make it with one of the tests, you got to have the 2s. All right, and now let's talk about pre-diabetes, okay? All right, so pre-diabetes, we use all the same tests, okay? So I'm just going to make it simple here. Fasting plasma glucose, sorry, that's a P. Fasting plasma glucose, we're talking about 100 to 125, okay? Not quite as high as diabetes. Glucose tolerance test, we're talking about 140 to 199, okay? Very good. And then what else? So we got A1C, very important here. A1C, I'm running out of room here, but A1C is 5.7 to 6.4%, all right? We're in the ranges here. And then lastly, well, that's all you need to know. Okay, just those 3. You got those 3, and then you got pre-diabetes. We'll talk a little bit about what you need to do with that later on, all right? Now let's talk about evaluation. So you got this patient, you came in, you diagnosed him with diabetes, all right? So what are you going to do? What are you going to do? Well, first thing you're going to do, obviously, you're going to take a history and a physical exam, all right? After that, you want to evaluate any nutrition, right, and weight loss. You want to know if they lost any weight recently. Then you want to assess the physical activity. This is a no-brainer, right? Physically active people, less likely to have diabetes. You want to know what they're doing. Or is there room for improvement, or are they already pretty physically active and they just have diabetes? You got to know that. Cardiovascular risk factors. F. Cardiovascular risk factors. What we're talking about family history, we're talking about age, sex, we're talking about smoking, we're talking about diabetes, hypertension, high cholesterol, we're talking about obesity, we're talking about diet, we're talking about physical activity, all of it. You need to get it all right? All the cardiovascular risk factors you want to ask about. Okay, and then what else are we going to talk about? We're going to talk about any history of diabetes related complications, okay? DM complications. You want to know if they got any neuropathy. You want to know if they got any retinopathy. These are the things that we're asking because we want to know how far the disease has progressed thus far. All right. Next, we want to ask about how often they have DKA. If they're type 1 diabetic, sorry, how often are they having episodes of DKA? DKA frequency. Then, of course, one of the risk factors, family history, important to know. Family history of diabetes specifically, do they have diabetes? All right, and then current management. Do they know they have diabetes? Have they ever been told they have diabetes and they're just not telling you? Are they taking any medications that they don't know about? Ask them about all of it, all of it. If they do have diabetes and it just hasn't been measured in a long time, 2 to 3 months, greater than 2 to 3 months, go ahead and get yourself an A1C. If it's been greater than 2 to 3 months, go ahead and get your A1C. All right, other labs to get. Other labs. Kind of running out of room here, but you got to bear with me. Other labs that you want to get. If a patient hasn't had a fasting lipid, newly diagnosed patient haven't had fasting lipid, you want to get fasting lipids. If it hasn't been 1 year, all right? These are all 1 year. If it's been greater than 1 year since they've had these, get a fasting lipid, and then you want to get a liver function test, all right? And then you want to get urine albumin. You want to assess the kidney function, all right? Urine albumin. Urine albumin to creatinine ratio, okay? And then, and only then, are you ready to proceed with the next steps, right? At this point, you want to assess, all right, these are all the things you want to assess for any patient with diabetes. But then at this point, if you do have a patient with type 1 diabetes, you want to ask a little bit deeper questions, all right? Newly diagnosed, there's a lot of factors, there's a lot of diseases that coincide with type 1 diabetes. It is an autoimmune condition. You need to assess the TSH. Do they have any thyroid problems? All right, you need to check for celiac antibodies. Come on. You want to see if they got any other related autoimmune conditions. Come on, it's a no-brainer. And then, of course, if you're not sure if they have type 1 or type 2 diabetes, there are additional tests that you can do to evaluate this, all right? If you don't know and you suspect they have type 1 diabetes, go ahead and get you an islet cell antibody test, okay? Antibody test. On top of that, you can also get a GAD65. Don't ask me what this is. I don't know, but it's important. It tells you if they have it or not. Next, we want to talk about treatment goals. Okay, we're looking at an A1C less than or equal to 7.0. That is your treatment goal. That is where you want your patients to be. Yet, it doesn't always have to be that high. If you want your patient to be alive and they have risk factors such as being elderly, or if they just have a limited life expectancy, then you can aim for a little bit higher, but this is generally what we're looking for. Then you want to try to reduce cardiovascular risk factors. This is the top priority. Cardiovascular risk factor reduction, okay? How do we do this, all right? I'm going to go over here. So I have a little bit, oh, sorry, I'm going to go down here. So I don't have that much room. All right, we're going to just bear with me, all right? So we're going to talk about the risk factor reduction, smoking cessation, okay? We're going to talk about blood pressure control, okay? We've talked about that before. Okay, and then we're going to talk about diet, exercise, weight loss, right? Or maintenance. Diet, exercise, weight loss. You're worried about the weight. And then we're going to talk about aspirin when necessary, okay? And only when necessary. And when is necessary? Well, it is necessary when a patient is 50 to 59 years old, all right? They do not have a bleeding risk. No bleeding risk, okay? There is no bleeding risk. They are 50 to 59 years old, and they have an atherosclerotic cardiovascular disease risk factor within the next 10 years of 10%. So I'm going to write that ASCVD, 10 years, greater than or equal to 10%, percent sign. All right. Now, what else do we want to do? Well, important to educate your patients. Education is key. Education. I clearly didn't have a good one because I could barely spell that word. But anyway, we're talking about education here, all right? So when we're educating our patients, we're focusing on weight reduction, calorie consistency. These are the keys. Weight reduction, calorie consistency. We want them to be consistent with the calories because if they have to be started on insulin, you don't want them to be very high hypoglycemic one day and then hypoglycemic the next day, and they take the same amount of insulin, and then next thing you know, they're in the ER bottomed out because they're way too hypoglycemic, all right? These are things that we have to prevent with diabetes education, all right? Next, we want to worry about the rest of the stuff that they do, all right? We're not worried. Monitoring, all right? Monitoring, if the blood glucose is at goal, which is less than or equal to 7% A1C, at that point we can result to twice a year, okay? Twice yearly. If they're not at goal, every 3 months, all right? A1C shows you blood glucose over the past 3 months. That's what we want to do. We're going to check that, all right? Let's talk about pharmacology, all right? We start pharmacology when the A1C is at 7.5 or greater, 7.5% or greater, okay? And then at that point, and only at that point, we can start medications with lifestyle modifications, right? So if the patient seems motivated and they seem like they might actually drop that A1C and they're close to target, you can give them 3 months for lifestyle modifications. They come back 3 months, the better, great. If they're not, start them on a medication, all right? There is no right medication to start, but we generally start with metformin. Why? Because metformin, fairly safe, it is cardioprotective, and it is a cheap medication. It is a good option. So we usually start with metformin. Other medications that are have been shown to reduce cardiovascular risk factors, cardiovascular disease decrease, okay, including metformin, are going to be your GLP-1s, GLP-1 agonist, all right, and then also your SGLT2s, SGLT2s. These drugs are good, okay. We are interested in using these drugs. However, there is some caveat with these two drugs, okay, the SGLT2s and metformin. We don't want to use them if the GFR is below 45, okay? Why? Because they're excreted by the kidney, and if you don't do it, then you're going to damage the kidney, and it's just not a good idea, right? So we want to take that into consideration. So a patient with chronic kidney disease with a GFR below 45 or very contraindicated below 30, we're going to instead use sulfonylureas or, and this is according to up-to-date, repaglinides, okay? However you spell it, repaglinides. Getting kind of lazy here with my writing, bear with me. And then, you know, if a patient is pretty far from goal, right, the A1C, you got an A1C of, let's say, 9 to 10%, then what we want to do is we want to just go straight to insulin or a GLP-1. All right, go ahead and get them started. They need the heavy-duty load. They're way too far from goal. You can start them on other medications, but this is a recommendation from up to date. All right, and then if they have no cardiovascular disease, but for whatever reason, whether it be GI upset, whatever, they can't take metformin, then you want to go ahead and use any of the other drugs that you deem fit, okay? Thank you for listening. This was Diabetes Diagnosis and Treatment.